Good afternoon, everyone. Hello, everybody. Woo.
Got some reverb.
Okay, we now have a quorum, and I can call this meeting together. We will go forth, and House Bill 173, LC 610044. The author is Representative Taylor, and you have the floor, Representative.
Thank you, Madam Chair. Today I bring to the committee House Bill 173, and we're working off of LC 610044. This is a bill that is important. You've seen it before. It just did not get through the whole process. Right now, this is an informational bill. There are many diseases and things that can be treated through immunization and other safety features. This bill provides for the Department of Education to provide to parents and guardians of students entering the 6th grade information regarding recommendations for adolescent vaccinations. It's very straightforward. It can be electronic, it can be paper. These are things I think parents don't always get all the information. If they have additional questions, there's how you can contact to get more information. It does not require any immunizations. There is no pressure to go get them. This is purely informational. I'll be happy to answer any questions.
Presenter, Representative Cannon.
Thank you. This is great. I mean, for many of us, we feel like more information, the better. Correct. And I think there were some things just during this pandemic that this House did that could have been more like this. So I'm happy to see it. But how did you choose these specific?
These are ones the department and doctors, just in general, they know that these are the ones that are important, and that
able to be vaccinated.
Right. And they have a great saving. I mean, if you will get these, you will prevent diseases, and that's what we're trying to do. We want healthy Jordans.
So there are no other...
There may be others that someone might want, but these were ones I thought were very vital right now that needed to be addressed.
Okay, yep. I think there could be some other things added. Thank you.
Mm-hmm.
Okay. Representative Osteen?
Thank you, Madam Chair. I have a quick question.
Yes.
Tell me where the Department of Education is going to get this information
From the department.
from.
Public Health Department will provide the information.
Thank you, Madam Chair. Thank you, Chairwoman Taylor, for bringing this bill back. I remember last session we had a very robust discussion with great support from all members of the committee, because we do feel that information sharing is critical for the people of this state. And I think most people on this committee felt that it's not good to feel like we're hiding the ball with resources that we already put in place and provide information for. It's just maximizing the money that we do spend already to make the information available. I have one quick question for you. On line 26, I'm trying to remember if this update was in there last year or not. We're going from, we marked through grade 6 and we put grade 7 through 12. Is that a new change, or was that in there last time?
I didn't carry the bill last year, so this,
Okay.
Yeah.
Okay, I mean, it doesn't make or break me. At 6th
No.
or 7th grade, either one is fine. I can see someone advocating for 7th grade because the child is a little bit older,
Right.
and the information will probably be more presentable, if you will, at that point. But thank you again for bringing this, and Madam Chair, at the appropriate time, I would like to move this bill.
Thank you, and thank you for bringing this bill. I just wanted to reiterate that this does not mandate vaccine. We're only providing information to the parents.
That's correct.
not
This
true?
is informational only.
Yeah, and this does not impose new regulations We're just
None.
providing information.
No.
I think it's a great bill. Thank you for bringing it.
Thank you.
Representative Steen? Steen?
One more thing. I am a fan of this bill too. I just, wanted to point out how most of the time, when parents go to the, health department to have the kids' vaccinations, that's the first time they've heard of other vaccinations and then they try to encourage you to vaccinate your child on something that you really don't know anything about. So I think it's great to have information ahead of time, do your own research, decide if this is the right thing for you to do or not. So again, I'm a fan. Thank you.
Thank you.
Steve Howard?
Thank you, Madam Chairman. Great bill. I think we went over this last year as well. I guess my question is, I don't have children in school, so how is this disseminated? At registration, or is it
It can be
email?
done, we're not putting direct exactly what each school has to do. It can be done electronically. Most schools now have a website. It'll be posted on a website. They can send it paper to a parent as a handout, or they can do it electronically. A lot of parents have online where they correspond with the school, and it can be sent out that way. It's totally up to them.
And the second part, Madam Chair. And so is this a mandate for the schools to do this once
Yes.
it's passed?
This is a mandate. The schools will
Thank you.
have to provide this information.
All right.
Representative Oliver?
On line 15, you refer to students entering the 6th grade, and then on line 26, it goes from 6 to 7. And it may be that there's a purpose on that. I just haven't absorbed it sufficiently to understand if that was intentional or unintentional.
You are right. I did not catch that. It's to be 7. I'll need to get the scribbler's fix on that. if
You
I
would
could.
accept an amendment for line 15 to go to the 7th
Right.
if someone wants to offer that.
At the appropriate time? We just move, I think we're supposed to move on the bill or get an opinion on the bill. Representative Renner?
Madam Chair, that's exactly what I was getting ready to point out as well.
Thank you, Madam Chair. If this is a mandate, how are we going to assure that it's being done?
This will be up to the local school boards and the Department of Education to verify that this is part of their curriculum and part of their jobs, and it will be part of it. It'll be checked through them.
Thank you.
Wait, Representative Cannon?
Just to double back down on this, so why not add COVID-19?
It just wasn't part of it. These were just, I guess, a different class that I was looking at right now. It's for adolescents, and it's not always, we've seen children and adolescents didn't need COVID as much. I just was addressing what was important and suggested for adolescents.
All right, we done it? Okay, we have the questions. Okay, Teddy?
Madam Chair, as it relates to House Bill 173, LC 610044, I move we do pass.
Do I have a second? Okay, Representative Olive?
As an amendment to line 15, that 6th be replaced with 7th.
Correct.
Thank you. Do I have a motion?
So moved.
Okay, second? Second. Everyone in favor of changing 6 to 7th on line 15, say aye. Aye. Anyone opposed? No? Okay, the ayes have it. That was the only one amendment, I believe. And so that sends us back to where we are, we'll be voting on the bill. So we have, we've had a first and a second. Is there any more discussion? Okay, everyone in the favor of the passage of House Bill 173 as amended, say aye. Aye. Anyone opposed, say no. Okay, the bill has passed as amended.
Thank you very much.
Okay, so, and you also have House Bill 291, so we're ready for that. So we have House Bill 291, and that's LC 520735S. Everybody got it? Okay, Representative
Thank you, Madam Chair. Today, I think we all know and recognize Georgia is making a great investment in our healthcare system through medical education, residency programs, nursing schools. Now we need to make sure that healthcare is going to be delivered. And I think one of these answers that may be helpful are the community healthcare workers. They will help us to make sure that the care that's needed is being delivered, and the folks in our communities will know about it. Community healthcare workers are in pursuit, and they're a great asset to having healthier, thriving Georgians. They play a pivotal role. The core strength lies in their ability to have trust within their own communities. As you know, we are a very diverse state, and a lot of times people have to build that strength with their medical providers, and that community healthcare workers do just that. They complement existing healthcare professionals, serving as an additional support for the patients. This is a collaborative approach to help bridge gaps in care, ensuring that everybody is included and information is gotten to the patients. In the communities, there's a great outreach that they do. They go beyond just the little bit. They are there for the patients. In this, they provide vital education, attending local events to foster trust in the communities, and they help to advocate for additional resources where they're needed. I think this is a bill will support a state-recognized certification program, and that's what this bill does. It describes and builds a certification program. It provides a career pathways, its opportunities, particularly in rural areas where we don't always have enough providers, and providers' offices also don't always have enough time to do the follow-up, and this will help patients in that way. These efforts align with the Department of Public Health strategy and plan to increase skilled public health care workers. The role of the community health care workers is indispensable in fostering health care in the system that we have. I think that by investing in certification, the community health care workers not only enhance the workforce, but also pave the way for better health care resources throughout the state. I'll be happy to answer any questions.
Representative Oliver.
This is not a licensure bill.
No, it is not a license. It is a certification only. They will not be providing hands-on medical care of any type. It's to be a guide through the system, helping them. They may need help to get to an appointment, and they will be that bridge between the medical provider and within the community. Again, part of this has to do with how diverse we are, and I think this will be helpful to them.
I'm happy to support it. I'm just curious whether the history of other license holders today began as a certification, and then I'm curious kind of who is the impetus behind this bill to provide this new certification process.
I was not preparing to bring a license for this. This is just purely not hands-on, so I felt like this is a good resource to make sure, again, we're making a tremendous investment in healthcare, and I want to make sure that people know how to use it and can get the care that they need. This is sort of an in-between. There are organizations, I think some of them may have signed up if they wanted to speak to it.
Okay. Is there somebody, okay, wait a minute. Kim, do you want to speak to this one? Right, go ahead, to this issue. And identify yourself and who you're with.
Thank you very much. Thank you, Madam Chair. I'm Kim Jones, Executive Director of NAMI Georgia, and the very proud mother of a child with a mental health condition. This is a bill that the Georgia Mental Health Policy Partnership has been studying all summer. We meet every Friday at 1 o'clock to discuss the bills we want to support. Those with mental health conditions also have a hard time navigating the system, so we feel like this is a good certification that will bridge a gap for people who are experiencing mental health conditions as well. We're up to over 100 partners who have given us their logos to sign on to the work that we're doing, and we also support it as NAMI, the National Alliance of Mental Illness for Georgia. So thank you very much.
Kim, I think people are asking, how are they going to help? Give us an example of a hands-on, or, I mean, well, it's not hands-on, if you, but
So in the instance of like a person with a mental health condition, they also have health conditions as well. And so oftentimes either transportation is a problem, knowing exactly where to go is a problem, and having somebody who's been trained and certified to understand the system and how to navigate the system could be very helpful for them. Knowing that when somebody is in crisis, particularly with a mental health issue and or their family members, oftentimes they are struggling just to understand the system, much less to know where to go, when to go, how to go, and what the appropriate channels are.
I would add to that, when we had COVID, it would have been a lot more beneficial, it would have been very beneficial if we had had community healthcare workers that could reach within their own communities and get the information that needed to be disseminated among their communities. So it's not to, necessarily say, go get a shot, go do this. It's going to help them find out where do they need to go. They may need an orthopedist. They might say, see your family doctor and he'll help you. Or it may be that they need to help getting their prescriptions refilled. They don't have the funds to get it. It will direct them to where they can get the help that they need, whether it be for mental health or if it is for regular health care treatment. It doesn't necessarily go along with the one I just brought that has to do with immunizations, but it's getting information in the hands of the people of Georgia. Many of them do not know how to navigate through the healthcare system, and that's what these folks would be doing. And it is pretty structured. They have to go through educational classes, and they will have to be able to pass a test. They will have to go through that process. Every community is not the same. We're so diverse today. It's very difficult. I can use my own experience in my business. I had an employer group that 85% of the people were Vietnamese, and that was very difficult to deal with. Had they had a community resource person that they could go to, it would help them a lot to be able to know, no, it's safe, go to the doctors, and here's the doctors you can go to. So there's a lot to be said for our diversity, but now we need to deal with that diversity and make sure that the right care is being delivered where it's needed.
Okay. Representative Reese.
Yes, thank you. Just a few questions. Help me understand the structure here. This person will be housed where?
I'm going to ask our partner who is this expert on this.
And that
bill.
may lead to some more questions. So don't go too far, please, because this is where I need clarity in this arena. So your partner, where's the partner? Come on up, partner. I'm not the chairwoman. Thank you, ma'am.
Hello, I'm Natasha Taylor, Deputy Director of Georgia Watch. We lead the Georgia Community Health Worker Advocacy Coalition, and I'm also here representing the Georgia Community Health Worker Network. We have some members behind me as well. So your question is, where are they housed? So currently, community health workers are only grant funded. So they're housed at universities, they're housed at local foundations, like the Sickle Cell Foundation utilizes community health workers. The Cancer Coalitions utilize community health workers. Georgia Core utilizes community health workers.
So under this bill, where would they be?
Say that again?
Under this bill, where would they be housed?
So the certification is going to be housed under the Department of Public Health,
Okay.
who has long supported community health workers. There was a division, the Chronic Disease Division, where it was housed, but currently the Community Health Worker Initiative will be housed under the Department of Public Health.
So the community health workers, as defined in this bill, will be employees of the Department of Public Health? No. Okay.
So Department of Public Health will house the certification for community health workers. Currently, Emory University trains community health workers. Morehouse School of Medicine trains community health workers. There are other entities that provide the CDC core competency training to community health workers. They are trained all across our state, but there is not one place where that certification is ran through, so that we know where our community health workers are, whether or not they're certified, and where they are deployed, so that we can identify gaps where they are missing.
I guess I'm not getting to my question properly. Who's going to pay them? How do they get paid? And who's their supervisor?
They are only grant funded right now. Typically, under organizations, they're supervised by doctors, by nurses, by social workers. It depends, because community health workers address.
You're saying right now, but I'm saying if this bill passes.
Yes, sir.
Under this bill, who will be paying them? Not right now, but under this bill, who would be paying
That bill does not establish a funding structure for community health workers.
It just establishes certification.
Yes, it just establishes a certification, because 3 years ago, when we brought up the term community health workers, the question was asked, can I just wake up tomorrow and say I'm a community health worker. No, there's a core competency that community health workers go through.
See, now we get so well. I
Yes,
like that
I'm
answer
with
right
you.
there.
All
See,
right,
thank
I'll
you.
go with you now.
Thank you.
Yes,
You cleared it up
yes,
for me.
absolutely, absolutely.
Okay.
Step 2 is getting them sustainably funded.
Okay.
I would add that they can be hired by a clinic, an FQHC, a doctor's office, a hospital. There are a lot of places that could hire them. This does nothing saying who's going to hire them, how much they're paid. This is just to make sure if someone wants that. We've talked about it many times. I think Grady did a grant program years ago, a number of years ago, so that you had someone that went out into the community and reached those that are not getting medical services. And that's what this was around.
So, Madam Chair, what I'm understanding is that a few years ago, when this conversation came up, there was a concern about there not being structure around this
Correct.
capacity, and we needed a curriculum, if you will, or at least something to obtain to show that the person has work.
That's what this is all about.
So
So that they're all the same. You don't want one doing one thing and another. This is to put a program together. They're all trained the same and would have competency.
Thank you, Madam Chair.
Thank you.
Thank you, Madam Chair.
Representative Cameron.
Thank you. Thank you for bringing this. I do have a few questions. Starting with, you're creating a certification committee. Do other states do certification committees?
Every state would do it. I don't know of one that I can name to you, but I know that they do it in different manners.
Yes, yes. Texas has a certification committee. Boston has a certification committee. Florida has been certifying community health workers for many, many years.
And so how has that been going? Because my concern is that we are about to over-regulate, over-create, over-say what these well-qualified individuals are doing. So how is that going? What statistics do you have to show that this certification committee has been ideal?
I can get you the statistics, but it has been successful in every state, which is why we're modeling after those states. The key to this certification committee is that community health workers will sit on this committee along with other medical professionals so that they are creating the standards for their certification so that we're not marginalizing, but we're being inclusive to the amount, to the credentials for becoming certified as a community health worker.
Okay, Madam Chair, may I just one or two more, please? On line 20, it's defining community health worker, and it says, has a demonstrated knowledge or unusually close understanding. Why unusually close? Why wouldn't we just say a great why are we, I think the language there is a little...
Well, I use the example of an employer that I had was 85% Vietnamese. I think it would be helpful if it was a Vietnamese that helped them communicate. So if you have something unique in your community, that's what we're looking for, to tie healthcare enablers, helping people get to the doctors and the care that they need. And that's I guess, the example for me.
Right.
And it would be someone that would help you.
Typically,
Again, we had in my mind, a lot of times it's communication. They don't speak the same language. You might be in a Hispanic community, and it's someone that has that kind of a connection to them. The knowledge would be based on what they are learning when they're going through their training. And then the second part of it was, how do you connect with that community?
I think we could just say something that is not saying that it's an unusually close understanding, because if someone knows something well, it's not unusual. It would be they're culturally humble, they have humility around the issue, or people used to say culturally competent. So I'm not quite sure about line 20. I think that is strange. On line 48, I wanted to ask about, as you're setting up this committee, there's 11 members. You say one licensed physician or certified nurse midwife with a specialization in maternal and child health. I'm wondering why we don't just add a doula, because a doula is a community health worker of maternal issues. So why are we going to an OB who probably is working in an office, not going to community events? Why do we choose to go to the top tier instead of to the actual community health worker?
I'm glad you asked that question. One, for them to go back to the unusually close, that definition was created by community health workers, and the reason they call themselves unusually close, because it's one thing to live in a community, but to have a lived experience of someone that you're helping is another kind of key thing about community health workers. We see that a lot with mental health. People who've experienced what the people that they're helping are going through makes you a little bit more, what they termed unusually close as the Community Health Worker Coalition. For the doula piece, we are proud to be supported by Healthy Mothers, Healthy Babies, Georgia. And doulas want to be considered separate from community health workers. They don't want to be considered community health workers. They want to be considered doulas because they're going after their own levels of certification and reimbursement. So when we first started this movement, we agreed to keep the terms separate.
May I have one more, or is that it? I guess she's letting me have one more. Line 65, members of the committee may be removed under the same conditions of removal from the licensing boards. What is that section? It's just, it's a little soon to think about members of committees being removed with our maternal mortality review committee members all being removed. So just curious, what is that?
It's the standard. You have to have some way that if someone has lost trust or whatever reasons there could be, it would be the same thing. That is, these people that are on these community healthcare workers will be treated as anyone else would be. That's what this basically says. I can't quote you the code section, what it says, but it's holding them up to the same standards of other professional licensing boards.
Okay, thanks.
And Representative, every time we go back to the maternal mortality committee being changed and everybody being replaced, there is a reason for that. They crossed the line and broke a very strict HIPAA law and the very strict standard in that. And nobody would own up to it. Nobody would say who did it. And so the governor or whoever is in charge of that dismissed everybody on that committee. So I think it has been, I think that if they haven't replaced it and started the committee again, they are in the process of doing it. I know that interviews were being taken on that one. So that doesn't normally happen without serious cause. Representative Barnes.
Thank you, Madam Chair. Few questions. We'll go to page 1.
Okay.
All right. All right. Hey, it's line 19 through 21. How is this measured? How is this measured? How are we measuring if it's a trusted member? How are we measuring how much knowledge they had?
When they go through the training, there is a training program that they go through, and they will have to prove their competency when they go through the training. If they don't pass it, they will not be able to call themselves a community healthcare worker.
Okay. Are these people trained specifically per their community? So like you were giving an example of Asian. Is an Asian trained to go to the Asian community and specifically work with them?
It's free enterprise. People can work wherever they want to, but I think it is helpful if you have some way to connect. I just use that as an example of what I had seen, but it would apply to anything. If you are competent and you are able to meet the criteria for this training, then you would be able to work in that community. It's obviously up to the community that you're attached to. That's usually who the community health workers want to reach out to, their own, where they can be most beneficial.
Thank you. In line 32 through 35, what are the core competency means? What are the competencies that we're
It's going to be,
working towards?
go ahead. No, go ahead.
Sorry, there are 8 core competencies, which I can make sure to mail out. We just ran over from our Community Health Worker Advocacy Day, so I don't have it all on me, but I can make sure to email everyone the core competencies, but they were established by the CDC, and they're recognized in those states that have certification.
Okay, I have one more question, please. Which, on line 69, it says members shall serve without compensation on 68, but they will be reimbursed, and then on 69 by the department. Which department will reimburse them? Public health?
Yes, this is under public health.
Department
and
of Public Health.
Public health. And this is, public health. These are people serving on the committee. It's not paying expense for these. It's just things.
My concern is that we have public health community workers who have gone and earned degrees, and then we have these who can just go get a certificate and go out there and do the same thing. So I feel like
If I may answer that.
Go ahead. Thank you.
So we just had a community member testify across the street, Mr. Wright, who was dealing with sickle cell disease, right? Being treated very well at Grady by doctors, nurses, social workers, everything. He was connected with a community health worker through the Sickle Cell Foundation. She identified that he had a housing issue, which is why he wasn't remaining consistent on his medication. She identified he had transportation issues, which is why he wasn't making it to his appointment. So that community health worker found him safe housing, found him transportation, consistently checks on him. We happened to go be taking him furniture and found out that he was in the middle of a sickle cell crisis and had to rush him to Grady Hospital. He has no family. He had no one there. That community health worker stayed with him to advocate for him in the hospital. So it's that kind of extra missing piece when you're discharged from the hospital, when you're diagnosed with a chronic disease, that person that checks on you and says, what other factors are you dealing with that might make you not consistent with your treatment, that might make you not consistent with your medication or with your health? And that's that missing link that we're missing in our healthcare system.
Okay. Thanks.
I'm going to go back to Representative Reese, Teddy's question about, okay, if we train these people, I mean, and grants are one thing, but grants run out. I mean, is the end game to have them paid by Medicaid?
Yes.
So that's what you're going to be. What other states do this?
Again, Texas, Florida. Boston.
There's a number of them.
They pay Medicaid.
Yes, Medicaid
pays
pays
the,
for them.
Yes.
the workers. Okay. So that would be the end thing. If we train these people,
They are billed and coded at the federal level. All we need is a state plan amendment to make them reimbursable here in Georgia.
Okay. All right. Got that. Okay. Osteen, am I saying it wrong?
You are saying it right, Madam Chair.
Okay.
Thank you so much. So I'm trying to follow this too, so walk me through this.
Mhm.
Right? I'm sure that there's a question or two that's coming out of this. So this person, how many people can be a community worker in a community? Who? Like, I mean, there's 400 people in a hospital that work.
Mm-hmm.
People that work at the health department. How many people can just say, I want to go through the certificate? I guess that's how this arises. I can see a need in my community, decide I want to go through a certificate program, right?
Mm-hmm.
And that certificate program currently is at Emory and where else?
It's at Emory. It's been at Morehouse School of Medicine for 20 plus years.
Okay, so there's 2 places in the state that offers this training.
Yes.
How in the world are those 2 entities going to be able to train the plethora of people who want to do this?
The Department of Public Health, the Department of Public Health also has an online training available for community health workers as well. So it's 3.
The certificate program looks like what? So it's just an online,
It's a core competency training that's used nationwide.
and then you have to pass a test to receive the certificate.
At those universities or at those entities that offer the training, you typically pass the test.
What about the one that's online?
The Department of Public Health, no. But as long as you apply saying that you've gone through the core competencies, DPH will see that you've gone through the core competency training and issue a certification.
So there is no test that person has to take to assure them that they have.
There are tests throughout the modules on the DPH program. There are tests throughout the modules. It's not like a final that you take. Absolutely.
So let me tell you the problem that I have with that is like kids that go through the hunter safety course.
Mm-hmm.
I've heard kids do this. Turn the computer on, let the thing time out, and advance, and they never go through the course.
Mm-hmm.
Which is why somebody has a bill that's trying to teach it in the classroom. I think it's great. That's a problem, that you can go through the course online, and at the end of that course, you can just submit and say, I went through the program and I can become a community. That's a problem.
Right.
Number 2, how do these people, once they get certified, how do they get deployed? Like like if I go to the hospital, the social worker realizes that I need some home health care whenever I get discharged, how do these people get deployed? I know, I think you answered where they're gonna be housed. But how do they get deployed to go to the person that needs the help? Is that gonna come from a doctor's order? Is that just, or can I call myself and say I need help? How does that work?
No, again, this is why we're trying to establish a certification so that there's some core competency and consistency across the board in the curriculum. Currently, community health workers are employed by Emory Hospital, they're employed by Northside Hospital, they're employed by Grady, they're employed by other healthcare services in the room. So typically they employ their community health workers to ensure that you didn't just wake up tomorrow and say, this is what I want to do. So there is some sort of oversight there. But at Grady, they employ community health workers to address violence and gun violence in their hospitals. So they've seen a 99% decrease in the return of gun violence victims with the deployment of community health workers specifically trained in violence prevention. At Northside Hospital, they've seen a drastic decrease in cancer rates because of community health workers going out into the community, hosting health fairs, having women get mammograms, having men screened for prostate cancer. That's a successful program down in Albany that you may have heard of. So that's how community health workers are deployed. Again, they're employed by health systems. At universities, they utilize community health workers to conduct community health needs assessments. So entities see the use. They've already been deployed, as Chair Taylor said, around our COVID-19 response. And when nobody could get out and could have boots on the ground, community health workers were out educating around vaccine uptake and how to find treatment for care. So again, we have support from doctors, from nurses, from social workers, all other healthcare professionals, and we're not trying to take that away, which is why we don't want a licensure. We're just saying we already have an overworked healthcare force. This is just an added addition, help to help doctors, to help nurses, to help social workers ensure that those patients are getting addressed outside of their systems and getting their needs addressed.
Representative Drenner, I'm sorry if you got the place lit up like a Christmas tree, and so they were just writing down names.
Light over here's been on for 3 hours, Madam Chair, and I don't know why you won't call on me, because I have the easiest
I know
question
you are a
here.
brilliant PhD.
I know,
But
I
I can
know.
tell
And I
time
could
better than
just-
you. We've only been going for about 40 minutes, so not 3 hours. What you need?
First, let me say thank you very much for your advocacy day today. It was outstanding, and if more groups use green cards, that was very good. My comments about the bills, I appreciate it. I understand the intent. I think some of the language is just needs a little bit more clarity in specifically the commissioner comments. What commissioner, the department. We don't know which department. So I don't know if you want to tighten that up a little bit.
I was assuming in code, but that's fine. I understand that.
That to me, that's why you got a lot of the questions, was because we're not really familiar with who you're implying somebody that
Yeah.
we would just like to be more straightforward.
Okay.
Thank you, Chairman. I'm just looking at the big picture here. We know that the committee that we're having is going to do like oversight, come up with some ideas, but you're looking for uniformity and a standard that's set by everybody. So if you have a hospital here, a hospital there, they have their own in-house thing going on. It's community health workers. Even pharmacies have this going on. But what we're trying to do is get one standard that even if you call yourself that at Emory or Morehouse, it's still got to come through public health.
Yes.
So we're all on one page, so we know that everybody's competent in what they're doing.
Yes.
Okay, with that, if you're going to have public health, it's coming on the public health. Will the Secretary of State have to get involved at all as far as any certifications or renewing of certification? Everything can stay on the public health. So what I'm getting here is getting a standard that everybody has to follow, and whether it's a hospital, whether it's anybody that say, I want a community health worker to do what they do for our organization. Some of it's going to be Medicaid, but some of it could also be a private hospital, whoever, to say, look, we're going to pay our people because this is what we need them to do. We don't want readmissions, or we don't want all these things because it costs money. So I think that's what we need to see is mainly that uniformity, that oversight, and is having that regular curriculum that everybody's going to have so that we can all be on one page. And so when you don't have a problem of one saying, I'm a community health worker, but there are certain things that you're doing that's not to the level where it need to be, or they don't have all the information or resources that somebody else have. So now there's a disparity whenever it's not a standard, because it can be different, but at least everybody know the minimum and these extra things that we're talking about relating to the people. Really, you don't have to really put that in there, because that's going to be based on who's hiring them to look at the situation to say, this is the person that we need to do this. They know what they're doing, but this is that extra thing, even if it's a language barrier, and that'll be up to whoever does the hiring. But I think, this is good. This is what we're needing. I think we need a lot of places, because we do have a lot of people that be readmitted too early, or people don't have the resources they need, and that's causing more of a problem in a lot of our facilities. So thank you guys for what you're doing, I think, but it's important that we get that standard and have some oversight and uniformity.
I'd just like to add, that is, I've heard from our hospital, we have the frequent flyers, they come in every Saturday night. If somebody had seen them on Friday, they wouldn't have had an episode and ended up in the ER room. So this is part of what this is to do.
Right. And I've seen this over 35 years that we need more of this, help. Thank you.
Thank you.
Two more, and then I'm going to make okay, Representative Cannon, you had another one.
Thank you, Madam Chair. Line 125, we're at the end of the bill, and we're talking about if somebody says that they're a community health worker and they have not gone through this certification, that they would be in violation of this code section. My question is, what is the violation penalty? And I really want to bring this back home. This is somebody who's trying to help someone, and now they're going to be in violation because they didn't pay a fee and take a test.
You can help someone, you just cannot call yourself a community healthcare worker. We have people, I help people all the time, and I don't call myself a community healthcare worker. That's the difference. You cannot present yourself as a community health worker if you're not certified. That's what this means.
I think that's interesting that community health workers, knowing the work that they do, would seek to put something that says that somebody is now violating that by just to keep it real, a community health worker is somebody in the community. So I get that we're creating certified community health worker, but I'm a little shocked that we would be putting in, language around a violation, but not actually having a penalty. So I don't really understand why we have to have this section. And the last part is just on line 129. It says that they would pay a fee set by the department for that certification. What's that typical fee amount in other states, or kind of what is the department mentioned?
Typically it's $20, $25, and we've already been conducting surveys amongst the Georgia Community Health Worker Network as to what they think a fair fee would be. We also have community health workers in the room that understand the work that they do, that want this certification. And for the piece that you mentioned with in violation, there's also a grandfathering process that's being proposed to the committee. So if you've already been doing the work for 10, 15 years, that committee will have build in that grandfathering process for certifications as well.
Okay, but it's not in this bill. You're saying that the committee would do it?
Yes.
The committee will put things like that together. That's why you have the committee.
Yes.
Yeah, chicken and egg. Because it also says all training programs have to be approved by this committee.
Correct. They'll help to establish that criteria.
Okay.
Yes, ma'am. My question was, if there are people that are already doing hospitals and all that are already doing it now, and we're trying to get a standard like you were talking about, which makes total sense, are those hospitals that are doing it now not going to be able to do it, or are they going to have to fall under the guidelines that we are trying to create now?
They will continue. They're employed by a hospital to provide a service. What this means, it's not reimbursable. You cannot bill Medicaid for it. And there are those in our lower income that would need this help, and Medicaid will pay for it if these are put in place. That's what we're trying to make it, a certified program. Otherwise, it's not acceptable for any payer to pay. You have to have something to base your foundation of what you're doing. You have to be educated in the field, otherwise CMS will not allow you to be reimbursed.
But those hospitals are billing the same way now, are they billing?
They're not billing, they're not getting paid for it.
They're not getting paid for those
They're hiring
services?
somebody like they hire a nurse, and they don't line item bill it. I guess that's the way to put it.
They're grant funded solely at hospitals right now.
Okay.
Like, are they calling, okay, Julie, from the hospital, stand up, you're with whom? Do you have former people that were addicted to drugs helping in the maternal,
We do at our facility in Rome, yes, ma'am, in the neonatal peer program, yes, ma'am, we do have
okay,
that.
do you call them community health workers?
Not
or-
at this time, no, ma'am. We have the more traditional community health workers at Atrium that are going out into the community to work with social determinants of health. That's where we've focused our work with community health workers so far.
Okay, but.
Yes, ma'am.
you-
We
you
would
call
probably,
people- what
if
do
this
you-
certification comes into law, we would push more folks into doing that. We right now just cover the cost ourselves because we realize it cuts down on readmissions, as Representative Sharper said, and it cuts down on the cost when the patient does show back up. They're less sick than they were
Right.
before. Yes, ma'am.
And you get docked.
Yes.
If they go
yes.
back within 30
Absolutely.
days, then you
Absolutely.
get docked
and,
on
and
it.
it's just better for the patient
Well,
not
of
to have
course,
to come back to the
it's better
hospital.
not
Yes,
to have
ma'am.
to,
Yes,
to
ma'am.
come back. Okay, if it's okay with the representative, I think this needs to be worked on a little bit more.
Yes.
I would like for you to, whoever was here from, that was before you, Julie, the lady. I would like for you to get my office a copy of the core, and I'll get it out to the committee.
Right.
What we're talking about is this core competencies. And a little bit more about the standards. If you're going to do this, are these people background checked and fingerprinted?
If I may, Chair,
Just a minute, I'm going to get it.
I'm sorry, if I may, Chair.
I'm
there-
just asking.
Typically by their employers, they're already going through that process. So again, this is just creating, to the representative's point here, so that people just can't wake up and say, I'm a community health worker today. It's creating a standardized training for community health workers and recognizing that training by certifying them.
Okay,
But typically their employers would already be doing the background checks or the fingerprinting. If you're working at Morehouse School of Medicine or Grady, I'm assuming wherever you're being employed, that's where you would be going through that process.
okay, but you wouldn't just be like, you could say you were a certified community worker, whatever it is, and I would think that I needed health care in my home, and
It wouldn't work like that. So if I say if I go through the training, we have community health workers here, but if I go through the training to be a certified community health worker, I'm still looking for employment. So I still need to be employed somewhere. I can't just start going to people's doors and saying, this is what I do. So I would still need to be employed and deployed and overseen by an entity.
okay. I think we need a lot of work on this. Go ahead, Teddy.
This isn't like when someone is recuperating and you hire a sitter to come and stay with you. It's not that. It's more intense. You're employed by somebody in the medical field. It's not just going to a patient like you would a sitter or something after you've had surgery. So it's different. Does that make sense?
Is there material on the Texas or other states that are doing this, that explain it? And also, I think we'd have to have a fiscal note on this.
We'll get that. You'll have to ask for it, but yes, we will ask for that.
Okay, because that would,
It would have an impact on Medicaid.
Right.
But we won't know it until we get people in it. I guess that's where we're at.
Well, I sure would hate to get people in it. And
Right.
we go through the training, and then we'd get a response from Medicaid that we're not going to pay for it.
Yes.
Which
No, that's
we
correct.
frequently do
Yes.
get.
And Chair, if I may, people are already going through the training. As I said, Morehouse School of Medicine, Emory University, and DPH already provide this training. So we're just adding that credentialing of saying you are a certified community health worker.
But those individuals are being paid
By
By
grant
Grady
funds.
and
by
so
gra-
forth.
Yes, by
Not-
grant funds.
with this overall
That's
movement
correct.
to have Medicaid pay for it.
And that is a separate state plan amendment that would need to happen. It's separate from certification.
Okay, well, then that's what I'm talking about.
Yes.
We would have to know, I mean, we have to have some idea of what this would cost the state. And not, and, okay,
Again, I'm not asking for it to be part of ours yet. This is just in preparation for it. This is to get the classes going, get people if they want to do it. And right now, they can be hired by one of the entities that want to pay it or that have grant funds to pay it through. This is to give it a name, give it an entity, so that you can then say, here is this block of community health workers. That's the difference.
Chairman, can I got something that can help all this. But I'll wait in turn. Go ahead.
Okay, you've got, go ahead, just briefly.
Okay, here's the thing. I think what we're doing here is we're looking at too many different, thank you, Chairman. I think we're looking at too many different things up here from this body. A lot of the things that we are thinking about and asking about, we are focusing on the committee is gonna do what they're gonna do. All right, they're gonna make sure everything is in line, everything they need. This is not even about the other financial end. This is saying, this is the certification, it's gonna be this much for the fee. At that point, that's where we're trying to get to. That's what we're trying to get to. That's the A part of what we're trying to do. And if we can focus on that, let them do what they're gonna do, and whoever pays them, that's for whoever and however they get paid, that's their business. We just trying to get the certification, and this committee is gonna
Thank you.
frame all this and say, this is what a certified community health worker is. Here you go. So that's all we're doing here. But it's been complicated. But we just trying to get the certification, get the committee. We're trying to vote on them having the opportunity to get a committee to create the certification and the parameters and everything. That's it.
As long as it's understood that the state may never put them on our Medicaid.
Right. It could be,
That's
it
right.
may stay
You know,
private the
because
whole
I
way.
don't want people to go take this certification thinking that there'll be all these jobs out there, and for whatever financial reasons, no matter how good they are and how we could use them, the state doesn't ever change our Medicaid thing. So I just don't believe in, and then if we,
Even
Okay.
if they don't ever approve it in Medicaid, which would be a separate bill, and it would take funding, it would make them all get the same criteria. And we would know when you call yourself a doctor, you're a doctor of whatever your specialty is. If you are a community health aide, you're all going to be
Understand.
getting the same education and be doing the same services. That's basically, we did wander off the reservation.
okay. Teddy, you want to make and I'll work with the chairman, get some information. about-
Well, Madam Chair, I don't think we think this is a bad bill. I think there's just too many
No,
questions here
it
today.
just needs work.
And I don't think it, I think it'd better serve if we could just get clarity, like, on those core values and actually let me see them, and some of the
Teddy,
things you wanted clarity on.
Teddy,
So
I thought you wanted to move. I'm not saying,
we're moving to table it.
right.
Yes, so I move
That's,
I move
I
to
mean,
table.
because I'm not saying it's a bad bill.
Yeah.
I asked for the
I just want to
information
be
for
clear.
you, so I
Okay.
just want you to make a motion if you still want to make it.
So move.
Thank you. Do I have a second to table the bill? We've got a motion to table it.
Thank you, Madam Chairman and Committee.
Okay.
We will fine tune this and be
Okay.
much clearer
All
about
right, we
it.
need a vote. Everyone in favor of tabling the bill, say aye. Anyone opposed? No? Okay. Please get us just as much information to her so that we can all still feel more comfortable with moving this bill.
I agree. Thank
Thank
you.
you, Chair. Thank you, Committee.